Dear colleagues, first I would like to thank the organizing committee and the scientific committee, especially my friend Professor Ina Shatut. It's at least the fifth time I participate to the AASD Annual International Conference. It's my pleasure to discuss with you a question which didn't exist 10 years before. Is insulin still the best injectable therapy in diabetes? Here is my agenda. First, what's injectable therapies in diabetes? Then injectable therapies face to face, followed by objectives for a good care for diabetes, and the injectable therapies in the guidelines before the conclusion. So, what are the injectable therapies? Of course, insulin, known 1 century before. And since 2005, the GLP-1 receptor agonist. But to be complete, we have also to mention amylin mimetics, even their use is limited. So we have here insulin. Insulin is the unique anti-hyperglycemic hormone. Insulin and insulin analogs are safe with less hypoglycemia. Insulin has also metabolic effects on lipids and proteins. Glucagon-like peptide 1 is an antisin hormone which have systemic action, and the goal is to decrease the rate of glycemia in the blood. We have multiple actions, but some of these actions are being confirmed in human. We have action on brain, decrease of food intake, water intake, increase of neuroprotection, of neurogenesis. We have actions on the heart and vessels, increase of glucose utilization, increase of cardioprotection, increase of cardiac output, increase of vasodilatation, and decrease of fatty acid metabolism. We have effects on kidney, increase of diuresis, natriuresis, effects on immune system with decrease of inflammation, in skeletal muscle with the increase of perfusion and the glucose uptake. We have effects on white and brown tissue. We have effects on liver with the decrease of steatosis and VLDL and the glucose production. Effects on gut and of pancreas with the results the decrease of the rate of glycemia. Amylin helps regulate postprandial glycemia by multiple mechanisms, but in my presentation, we will focus our interest only on insulin and GLP-1 receptor agonist face-to-face. Are there any advantage or situation to use insulin preferentially rather than GLP-1 receptor agonist? Of course, insulin is the unique way for type 1 diabetes to survive. In the case of chronic kidney deficiency, most of type 2 diabetes require the need of insulin because of its safety, but GLP-1 receptor agonists, like for example dulaglutide, can also be useful. In most naive patients with type 2 diabetes, insulin is well accepted with an improvement of the best imaginable health for the patient, like here in Iwanachi study, the Moroccan cohort. Insulin can be delivered by pump, unlike GLP-1 receptor agonist. But this way requires also some catheter injection each 1 to 3 days. On the other hand, GLP-1 receptor agonist can be injected only once a week. And till now, we have four approved FDA for this once weekly dosing: exenatide, albiglutide, dulaglutide, and semaglutide. The injection barriers have pushed to imagine other ways to introduce these drugs, insulin, for example, and we have inhaled insulin is now used, but only as very short-acting insulin, 12 minutes, in patients without respiratory disease. In addition, oral insulin is in the pipe, but slowly. The research starts on 2008, I think, and we have in maybe phase 2 or 3. But on the other hand, FDA has approved the first oral GLP-1 receptor agonist treatment for type 2 diabetes last year. It's semaglutide. And because of union is strength, the competition between the two drugs have to be with peace. So we have fixed those combination of GLP-1 receptor agonist and basal insulin analogs. We have two combinations. We have liraglutide degludec with degludec combined with degludec, and we have lixisenatide with glargine. And these products combined have a very high efficacy, but a very high cost. The current objectives for a good care for type 2 diabetes is first, efficacy, the goal of hemoglobin 1C. No hypoglycemia, sure, especially in the elderly. Security of use, cardiovascular risk factor. We will discuss this important parameter. Weight decrease, but also certain interesting parameters for the objective of good care for type 2 diabetes, like quality of life, patient satisfaction, and of course, cost. The cardiovascular outcome trials have emerged after the rosiglitazone case. And here is a brief history of this question according to FDA. We can see 2008 FDA guidelines mandating assessment of cardiovascular safety of all anti-hyperglycemic agents in randomized controlled trials. Designated as non-inferiority studies to demonstrate study drug was not associated with more major adverse cardiovascular events than placebo. Some study designs tested for superiority if non-inferiority criteria were met. For the primary endpoints, there is composite of cardiovascular death, non-fatal myocardial infarction, and non-fatal stroke. Some primary endpoints included additional components. So study safety trials are being conducted for each compound within the newer classes. So since 2013 till now, we have all the new products, anti-diabetic products, must have cardiovascular outcome trials and demonstrates that there is no inferiority with the placebo. So we have here in blue the DPP4 inhibitor cardiovascular outcomes here. In red, we have SGLT2 inhibitor cardiovascular outcomes. And in orange, we have the GLP-1 receptor agonist outcomes trials. So here is a recent meta analysis, and surprising, the diabetology world, not only all the GLP-1 receptor agonists tested for maize demonstrated their non-inferiority versus placebo, but some of them show their superiority in the situation, especially in the situation of a history of cardiovascular disease. We have here the leader study with the liraglutide, the SUSTAIN 6 study with semaglutide that demonstrated that their superiority versus placebo in the cardiovascular atherosclerosis cardiovascular disease. And that's why the American Diabetes Association has recently changed its position. So we have always the first line therapy metformin, but after metformin, with metformin, if we have indication of high risk or established atherosclerosis cardiovascular disease or chronic kidney disease or heart failure, we have to consider independently of baseline A1C or individualized A1C targets. Even we have a normal goal of A1C, we have to discuss. If you have atherosclerosis cardiovascular disease predominant, like establishes ICVD, or an indication of high SCVD risk, we have to prefer to add GLP-1 receptor agonist with proven CVD benefits rather than insulin. The same, if you have a heart failure or chronic kidney disease predominant, we have also to add SGLT2 or GLP-1 receptor agonist rather than insulin. But if we have no indicator of high risk of established CVD, CKD, or heart failure, and if hemoglobin 1C after metformin, if individualized target is not reached, we have to, and if we have to we need to minimize hypoglycemia, we have to add to metformin, we have to add GLP-1 receptor agonists or other products, but not yet basal insulin. The same thing, if we need to minimize weight gain or promote weight loss, we have to choose, for example, GLP-1 receptor agonist rather than insulin. The unique situation when we have no to prescribe GLP-1 receptor agonist, it's simply when the cost is a major issue. And the European Society of Cardiology guideline on diabetes, developed in collaboration with the AASD, consider that type 2 diabetes, drug-naive patient, we have to consider ICVD or high or very high cardiovascular risk, like target organ damage or multiple risk factor. And in this situation, we have to prescribe SGLT2 or GLP-1 receptor agonist before prescribing metformin. It's a new in this recommendation, but not in the American Diabetes association recommendation. And in type 2 diabetes or metformin, even for example, the hemoglobin A1C is normal. We have, if we have ACVD or high or very high cardiovascular risk, we have to add a SGLT2 inhibitor or GLP-1 receptor agonist, like the guideline of American Diabetes Association. So, however, if the straight line represents the recommendation, the reality is so complex and depends on many factors. One of these factors is the income of the country. As we can see here in this recent meta-analysis, in low income countries, here in blue, we have, for example, for surveillance, we have no guidelines. For cardiovascular comorbidities and non-cardiovascular comorbidities, no guidelines. There is no blue here. But the orange, high income countries, we have, for all the items, we have guidelines very well developed. So, according to the power of the international guidelines, GLP-1 receptor agonist market size is growing. And for example, in United States of America, it's represented about $4 billion on 2016, and it will reach more than 10,000 or $10 billion in 2027. To conclude, here is some key message. In most patients who need the greater glucose lowering effect of an injectable medication, GLP-1 receptor agonists are preferred to insulin. GLP-1 receptor agonists had a lower risk of hypoglycemia and beneficial effects on body weight compared with insulin. Institutes reporting randomized trials reporting statistically significant reduction in cardiovascular events for 3 FDA-approved glucagon-like peptide-1 receptor agonists. GLP-1 receptor agonist once a week, very easy. GLP-1 receptor agonist costly. Health is priceless, but it comes at a cost. Insulin and GLP-1 receptor agonists can be associated for a better efficacy. In the real life, the best at all doesn't exist. And the best depends on the context. Thank you very much for your attention. And here is the Mosque Hassan II in Casablanca, Morocco. I wish you receiving you in Morocco next year, inshallah.